Hello friends, many of you have joined me on my WhatsApp group and I have been sending to all of you lot of last minute revision points. But many people have suggested that I should talk more about these points. So now I'm starting this series in which almost daily I'll be taking lecture in the evening around 4:15. And I'll be covering entire medicine. And entire medicine, I'll give you a summary. And I'll make you revise the entire medicine in just 3 hours time. And I assure you that at least 15 to 20% questions what you will be getting in your NEET exam will be based on the points which I will be discussing. Okay? So don't miss these lectures. So I'll be covering 15 to 20% question. Is a huge number that can turn around the table. Okay, so today, first topic of today is acute complication of diabetes. Okay, the first topic of the day is diabetes ketoacidosis. So I have got two questions for you. Okay, the first question is, which of the following is the best prognostic feature for a case of DKA? The options are potassium. Second is increased blood urea, or third is sodium level, third is ABG. So the first question is, which of the following is the best prognostic factor for a case of DKA? Potassium level, blood urea level, sodium level, or arterial blood gas analysis. Best prognostic feature. Okay. And second question is, suppose all of you know infection is a very important precipitating factor. Which of the following indicate the patient has infection as a precipitating? Number one, altered sensorium. That means patient is comatose. Second, very high TLC count, so-called leukocytosis. Third, BP is low. Fourth is patient has fever. So there are two questions in front of you. You get 60 seconds to think and write the answer. Okay, just write down the answer, question number one and two. Okay, your time start now. The first question is best prognostic feature of a case of diabetes ketoacidosis. Potassium level, blood urea level, sodium level, or arterial blood gas analysis. Infection as a precipitating factor is indicated by which of the following parameters? Altered sensorium, that is patient is in comatose state. Increased TLC, that is leukocytosis. Third is low BP, hypotension. Fourth is the fever. I hope you have written the question answer. Write down your answer A, B, C, D, whatever you have, 1 and 2. So I presume by now you have done it. So let's talk about DKA. And after that, I'll give you summary also, but all you have to remember. Diabetes ketoacidosis. First point, it is more in type 1 diabetes as compared to type 2 diabetes. But it doesn't mean that it will never happen in type 2 diabetes. It does occur, but more in children or type 1 diabetes. Classical feature is patient come with nausea, vomiting, and pain abdomen. Pain abdomen. This is a very, very important feature. Very, very important feature. This question comes almost every year. Patient has marked dehydration. Marked dehydration. Why? because of osmotic diuresis. Osmotic diuresis. Okay. So that's why patient has low BP. So low BP is usually secondary to dehydration, and that lead to tachycardia, increased heart rate. So increased heart rate is also the question which came last year NEET exam. Now what else are the features in this case? Usually sugar value is in the range of 300 to 600 milligram percent. Okay. Now in this patient, hyponatremia occurs, but this is due to pseudo hyponatremia. Pseudo hyponatremia. This again a very frequently asked question. Pseudo hyponatremia occurs. This is a concept. So before I proceed further about DKA, let me talk about what do you mean by pseudo hyponatremia. Yes, sodium level does go down, but it's not true, but it's pseudo. Again, let's learn what do you mean by pseudo. Suppose blood sugar is 100 milligram percent and sodium is say 135.6. This is sodium, normal. Now if the sugar goes up by 100 milligram, that means if sugar goes to 200 milligram percent, sodium will go down by 1.6 milliequivalent. With every 100 milligram rise of sugar, sodium will go down by 1.6. So if sodium glucose become 200, sodium will become 134. If sugar become 300, it will go down by 132.4. If my mathematics is good, I told like this thing. Now why it is so? Because as the sugar goes high, so the machine which is checking the sodium level gives false reading. So what the false reading is, with every rise of 100 milligram, it will show sodium to be less by 1.6. That's why we use the term as pseudo hyponatremia. Right? So I hope you understood what do you mean by pseudo hyponatremia. So again, before I proceed further, does pseudo hyponatremia occur only in DKA? No, there are many other causes. So note down, this is a very, very important question. Causes of pseudo hyponatremia are DKA, non-ketotic hyperosmolar coma, hyperlipidemia, and hyperproteinemia, classically what occurs in multiple myeloma, high amount of protein. So high amount of glucose in the blood, high amount of lipid in the blood, or high amount of protein in the blood, which typically what we see in multiple myeloma, you get pseudo hyponatremia. It's a very, very important question. All are important questions that you got to remember. So we move further. We come back to our DKA. We learned that extra thing about pseudo hyponatremia. What else occur in these patients? Leukocytosis occur. Increased TLC is a feature of all DKA. But if the patient has fever, this indicate infection. That indicate infection. So that's why the question number 2, the answer is fever is the answer. Infection is indicated by fever. not by increased TLC count, which is ordinary a feature of DKA. What else we get in these patients? You get metabolic acidosis with increased anion gap. And due to same reason, it lead to hyperkalemia. And due to marked dehydration, patient get increased blood urea. You can say it's developed type of pre-renal failure. Pre-renal failure. Pre-renal failure. Okay? Pre-renal failure occurs, marked increase in blood urea. But when we treat now, patient has come to us, and this is to be treated in the intensive care unit. It's never to be treated in the ward. It needs ICU treatment. So, how you are going to treat a case of DKA? Treatment of DKA, first of all, as the patient is markedly dehydrated, treatment, you have to give intravenous normal saline. You have to infuse very fast IV saline because he's dehydrated. Second, you give intravenous insulin, I for insulin. Which insulin is usually given? The answer is you give regular insulin. Regular insulin. Now, one more question for you. Listen to question very carefully and write down the answer in your copy. Suppose we give intravenous regular insulin to a patient of DKA. Its action will start in how much time? Listen to my question very carefully. There is one patient of DKA to whom I am giving IV insulin, regular insulin. The action of this insulin will start in how much time? Option is A, immediately. Immediately. Option B, in around 5 minutes. C, in around 7 minutes. D, in around 10 minutes. E, in around 13 minutes. You get 30 seconds to think and answer. Just write down the answer in your copy. You give IV regular insulin. The action will start what time? Immediately, by within 5 minutes, within 7 minutes, within 10 minutes, or within 13 minutes. Okay. Quickly. In 30 seconds, you should be able to write the answer. Yeah. The right answer is immediately. Immediately. So, when you give regular insulin, the action start immediately. Immediately. We want to start action immediately because it carries a very high mortality. Okay. Now, of course, if patient has infection, you have to give antibiotic also. Antibiotic also. Now, what are the complications of this case? Complication. Most dangerous complication is cerebral edema. Cerebral edema. Second complication is acute gastric dilatation. But this is the most dangerous complication. But we are treating a case, we have treated with saline, we have given regular insulin, and we are expecting this complication. Now, how do we really know the patient is improving, which is a prognostic factor. So let's see what happened. So patient has come to us at this stage. His sugar is 600 milligram. His blood sugar, and he has come at this stage. His sugar is 600. Potassium is 7. Urea is maybe 100. Okay, and he has pH of 7.21. This is the scenario with bicarbonate level of 10. It indicate what? It indicate severe metabolic acidosis. This is the patient at this stage. Now you give IV insulin. Sugar start coming down very fast. This is blood sugar. Potassium also start coming down very fast. And as we are giving a saline with insulin, even blood urea start, U for urea, also start coming down very fast. These things, they start coming very fast. But pH, which is 7.21, or we can say bicarb, this bicarbonate will rise slowly. pH is the last to get changed. Am I right? In fact, when the sugar comes around 200 or 250, now what we do that time? Because pH is still not come down. In this case, you start replacing sugar, glucose. You start giving dextrose. Remember, in the treatment of DKA, when the blood sugar come down around 250, you now start giving glucose. Of course, you continue giving insulin. You continue giving insulin, but you start giving sugar. Similarly, potassium level goes down very fast. And when potassium comes to around 4, you start replacing potassium also. Now start replacing potassium. Why? Because if you keep on giving, if you do not replace sugar, you do not replace potassium, you are giving insulin, the patient soon will go into hypoglycemia. Patient soon will go into hypokalemia, which is much more dangerous because this will take time. So friends, single most important prognostic factor is ABG. Because potassium level will come down very fast, even urea level will come down very fast. But remember, urea level will come down only if you are giving IV saline as a replacement. And sodium is a pseudo hyponatremia. As the sugar will go down, sodium level will also go down. It has nothing to do with prognosis. So arterial blood gas analysis, which is done by pH or bicarb, is the single most important precipitating factor. This question, both this question came last year NEET exam. So I thought I must do the latest question for you. Right, sir? This was regarding DKA. Now, second topic is non-ketotic hyperosmolar coma. Non-ketotic hyperosmolar coma. The features are, the clinical feature, number one, it classically occurs in elderly type 2 diabetic patient. Sugar value is in the range of 900 to 1100 milligram %. Point to be noted, in DKA it was somewhere around 300 to 600. Here it is 900 to 1100 milligram. Why is it so? Because in these patients, nausea, vomiting, pain, abdomen, they are classically not the feature. This was the latest question. This was the latest question. In these patients, nausea, vomiting, pain, trauma do not occur. And that's why their usually presentation is altered sensorium. Altered sensorium. Again, a question for you. Why? Because patient has very high sugar and that lead to marked dehydration. Marked dehydration. Dehydration is plus, 4 plus. That's why the BP is low. Pulse is very, very high. Why? In other words, you can say they are in hypovolemic shock. Okay? So in these patients, we have to treat the patient. Again, ICU treatment. You gave number 1, IV, regular insulin, the way we gave in, what we gave in DK. But in these patients, we tend to give N/2 saline. Okay? Usual is N/2 saline, but if BP, suppose patient come, his initial BP, systolic BP is only 80 mm of Hg. So systolic BP below 90, he is in hypovolemic shock. So initially we can give normal saline. But once the systolic BP is 90 or above 90 millimeter mercury, we replace with N/2 saline. So in the exam, if question come to you, they talk about treatment of non-ketotic hypersmall coma. If there is no mention about BP, then the answer should be N/2 saline. But if systolic BP is below 890, then you should give normal saline. And in these patients, one of the big problem is venous thrombosis. Venous thrombosis is a great problem in these patients because of marked dehydration, and an elderly person, they are prone to deep vein thrombus, which can go as a pulmonary embolism. Okay, so this is again a question for you. N/2 saline is a question for you. Now I have a simple question for you. All of you, this question come almost every year. Every year this question comes. The question is, I have one patient whose blood sugar is 900 milligram%, whose sodium is 135, whose potassium is 5, bicarb is 10, urea का BUN is 14 milligram%, chloride 104. You calculate the plasma osmolality of this patient. The question is, calculate the plasma osmolality of a patient whose sugar is 900, sodium 135, potassium 5, bicarb 10, BUN 14, chloride 104. This type of question come almost every year. So you calculate the plasma osmolality, you get 40 seconds to think and write the answer. Calculate and write, then I'll tell you how to do, and you check your answer. And your time starts now. Calculate the plasma osmolality of a patient whose sugar is 900 milligram%, of course. His sodium is 135 milliequivalent per liter, potassium 5 milliequivalent per liter, bicarb is 10 milliequivalent per liter, BUN is 14 milligram%, and chloride is 104 milliequivalent per liter. Okay, I hope by now You have done it. Now let's see how to calculate the plasma osmolality. The plasma osmolality is sodium plus potassium multiplied by 2 plus blood urea and blood sugar RBS plus BUN. This is 135 plus 5 multiplied by 2 plus sugar is in 900. It is in milligram person, but you have to convert into millimole per liter. So you divide 900 by 18 and BUN 14 you divide by 2.8. This is to convert into millimole per liter. So this comes out to be 140 and 280. This is 280. This is 50. This is 5. So in this case, the plasma osmolality is 335 milliosmol per liter. Got it? And normal plasma osmolality is somewhere between 280 to 300 is the plasma osmolality. So in our case, in non-ketotic hypersmol, sugar value is very, very high. That's why these patients are markedly dehydrated. Okay, that's why when we treat this case, we give N/2 saline because already osmosis is very, very high. You understood? So once the BP, systolic BP above 90, we switch over to N/2 saline. Well, now we talk about third acute complication of diabetes. Third acute complication of diabetes is lactic acidosis. It is more common in type 2 patients who are on metformin therapy, alcoholic. Number 2, in these patients, patient has metabolic acidosis with increased anion gap. So that's why hyperkalemia is also there. They have a Kussmaul breathing. Kussmaul breathing. Kussmaul breathing is nothing but acidotic breathing. Acidotic breathing is there. Right? And it carries a very high mortality. Treat the patient in ICU and your treatment is intravenous soda bicarb. This is the main treatment. Okay? But its mortality is very, very high. Mortality is as high as 50%. And one extra point, thiamine deficiency can also lead to lactic acidosis. This was the latest question. This question came in the last exams. And there are at least large number of conditions which can lead to lactic acidosis. So lactic acidosis occur not only in diabetes, there are many other conditions. So we have a classification. The name of classification is Cohen's classification. Cohen's classification. Okay. So this is about lactic acidosis. As I told you, more in type 2 diabetic patient, especially those are metformin or alcoholic patient. Metabolic acidosis with increased anion gap, hyperkalemia, small breathing, thiamine deficiency, and Cohen's classification. So now, let us see how much time we need to revise this entire acute complication. Okay? So, now comes the summary for which you have seen this lecture. Right? So, Last minute revision point, lecture number 1. These points you have to read a day before the exam. Let me see how much time we need to revise it. Will time also? Okay, the time start now. So DKA, dehydration, pain abdomen, altered sensorium, fever indicate infection, increased TLC is a feature, metabolic acidosis with increased saline gap, pseudo hyponatremia, increased blood urea, hyperkalemia. Treatment is IV insulin, I for insulin, normal saline. Salivary edema is a big problem. Non-ketotic hypersmolar coma, elderly, dehydration, marked dehydration, no nausea, vomiting, pain abdomen. Coma is a feature, and by 2 saline and IV insulin. Lactic acidosis, metformin, metabolic acidosis with increased saline gap, IV soda bicarb, thiamine deficiency, and Cohen's classification. Okay, so if I go for stopping, oh, it's running. Well, it is around 1 minute and 20 seconds. The time exceeded. It was somewhere around 1 minute and 10 seconds. So entire acute complication you could revise in just about 70-80 seconds only. And so I repeat again, you can, those who want to note down, you can note down now or you can see later on also. Anyway, I repeat again. DKA, dehydration, pain abdomen is a feature, altered sensorium, fever indicate infection, increased TLC count is a feature, metabolic acidosis with increased saline gap, pseudo hyponatremia, increased blood urea, hyperkalemia is a feature. You give IV regular insulin, saline, and salivary edema is the most dangerous complication. And non-ketotic hypersmolar coma, elderly people, dehydration plus, no nausea, vomiting, pain abdomen, coma plus, N by 2 saline and IV insulin. Lactic acidosis, metformin therapy, more common in metformin therapy. Metabolic acidosis with increased saline gap. Treatment is IV soda bicarb. Thiamine deficiency can also lead to lactic acidosis, and Cohen's classification is done. Okay. Those of you who are writing, I give you a few seconds more to write down. Otherwise, you can see again after this lecture. Well, friends, this is the summary of lecture 1, which you can revise only in 70 to 80 seconds. And whatever question of this topic, acute complication, will come, they will come from these points, so-called last minute revision point. I will be taking a series of lectures like this, and I'll first explain the basic fundamentals, and after that I'll give you the list of this type of points. You can make a summary of this, or in the exam a day before you read these points. And of course, on daily basis I'll be keep on continue sending last minute revision point of other subjects also, which if you read are more than enough. Remember, a good amount of question will come from what I am teaching you. So tomorrow again, I'll be talking to you, same time, 4:15. Get tuned to this thing. Please inform your other friend also. I hope by now you have written all this thing. And many of you have joined me on my WhatsApp. Otherwise, those who have not joined, you send me your name, your college name, in which city you are, your email ID, and which year you are studying, third year, pre-final, final, intern, post-intern, whatever you are, you give this information to me. I'll be sending you daily lot of information. Okay, I hope you like the lecture, you like the style, you like the content, and of course the most important is this summary, what you want, so that you are able to revise. Remember, almost whole medicine I'll make you revise in just 3 hours time, and 15 to 20% question will come from based on this point only. Please give feedback on Messenger or my WhatsApp. Please give feedback so that I know I want to serve you in the best possible way. Thank you very much for watching this video. Please tell your friends also to join it. Thank you very much. See you tomorrow at 4:15 p.m. again. Thank you very much. Yeah, my staff has told you have to send me at my WhatsApp number 99682 88832. This is my WhatsApp number. You have to send this information at this 99682 88832. Thanks to my staff who reminded me that I have forgot to write my number 99682 88832. This is my WhatsApp number. Okay, please give me feedback. I'll be waiting for your reply. Thank you very much. God bless all of you.